Good. Well, good afternoon. I'm Valerie Clark, Senior Vice President of Health Equity and Public Health at Ketchum, and delighted to moderate this last fireside chat. We're bringing up the rear, folks. So thank you for sticking with us. This has been a tremendous day full of gems, right? Storytelling is a powerful tool. Some actions, patient-centered versus person-centered. And of course, we were all inspired by Michelle and her story. So we thank you. Yes, absolutely. So I am joined by an esteemed panel. I'm going to allow them to introduce themselves in their own way. You're going to hear pharma, you're going to hear research, and you're going to hear provider. So listen out for that. And as they respond to the questions, they're going to bring a bit of that to the response. So esteemed panel, let's start with Rashad.
Hello, good afternoon, everyone. Good afternoon.
Good afternoon.
I'm Rashad Burgess. I'm Vice President of Advancing Health and Black Equity at Gilead Sciences. We're responsible for leading our global health equity strategy across our entire enterprise. I've been with Gilead just over 10 years. But what you should know about me is that my entire career, I have advocated, worked on behalf of, and come from communities that are oftentimes on the margins. And so it's exciting to be here. Thank you, blackdoctors.org, and all the organizations that have been a part of putting this on. Thanks for having me.
Terrific.
Good afternoon, everyone. My name is Paul Burton, and I am CMO at Amgen. I've been in that role for about 6 months. I was CMO of Moderna before that, and for a whole variety of reasons, we had to deal with a lot of health inequality and equity issues. So had a chance to kind of think about that there. And I would just say this has been a humbling day for me. I thought the panels were outstanding. I have learned so much from today, and I'm going to take so much back with me. So again, to the organizers, thank you. It's been an amazing day.
Absolutely.
My name is Dustin Duncan. I am Associate Dean for Health Equity Research at Columbia University, where I also serve as a professor of epidemiology. I newly started a foundation that my mom directs. It's called the Dustin Duncan Research Foundation. We're giving out grants for students in the fall, so be on the lookout for that, some socials, et cetera. Just broadly, my work is focused on sexual and gender minorities as one frame of health equity issues, with a particular focus on racial and ethnic compositions or understandings of that. A lot of my work focuses here domestically in the US, but I also do work within the Caribbean, particularly in the Eastern Caribbean and East Africa. At Columbia, we're building the Columbia East Africa Center for Sexual and Gender Minority Health Equity Research that I'm really excited and honored to co-lead with my colleagues who are on the ground there. Thank you.
Hi, everyone. My name is Dr. Omolara Uwemedimo. I've been a board-certified pediatrician for about 20 years and transitioned from academia to co-found Strong Children Wellness Medical Group. Strong Children Wellness is an innovative practice based in New York City, and what our goal is actually to remember that health doesn't begin in clinics, it begins in communities. And so what we do is we actually partner with community-based organizations and bring primary care, mental health, and social care coordination for children and families. We're at about 1,500 kids and families across New York City now. And also, as part of the international contingent, I am also a global health pediatrician, and I think that's really important for us to bring to light to this. One of the things I'm excited about is how we move beyond health equity to health justice, and really thinking about the fact that equity is really how do we solve those gaps, while health justice is really why do those gaps exist and how do we break those silos. So thank you again, Black Doctor. Super excited to be here.
All right. Awesome. I'm Derrick Lane. You all know me already. Chief Marketing Officer here at BDO, where wellness and culture connect. I'm just excited about today, excited about the partnerships that have already been formed, and excited about this panel. Thank you.
So as you could see from the introductions, I didn't even have to tell them to brag a bit. They've already got it. Terrific. So today we heard our first fireside chat was racism in medicine. Then we moved to clinical trials diversity. Then we talked about screening Black women and the Black community. this fireside chat really focuses on health equity leadership, right? Who's doing the work and what does it look like for 2024? So you're looking at the panel, that these are the people that are at the top, really making the decisions, garnering commitment, finding the resources to put there. And so we're going to talk a little bit about how they continue to do that in the middle of a full-on, right, assault on DE&I efforts, how they measure that, what's their approach and framework. And then we're going to end with, we hope, a little bit of inspiration about what they see on the horizon for 2024. Okay, so we're going to dive right in. Last fall, Supreme Court, affirmative action, we all know, we were there. We are living in it, right? There were commitments in 2020, racial reckoning, health equity. I love that health equity is our path to health justice, right? So where are we now? And how do, we're leaders in our position, our organizations and our teams, how do we continue to keep up the commitment for health equity, keeping our foot on the gas to make sure that this isn't going to fall by the wayside, especially in 2024? Anyone can take that.
Maybe I can start. So listen, I think we're in danger, serious danger of losing a commitment to health equity. In 2020, I was still at J&J, the murder of George Floyd. We used to have twice a week, we're in the middle of COVID, right? Sessions where we would all get on a call, our group of 70 people, and just share reflections on how do people feel about that. And, they were difficult discussions to have. I am a middle-aged white guy. I have not ever talked about things like that. People were opening up and it was fantastic, really fantastic. But it stopped, it stopped. I go on the BBC website. Ukraine used to be #1. People are dying all the time, right? Where is it now? It's like 8th down on the list. Human nature is that once you've dealt with a tricky situation and you think you've fixed it, I think you move on. I think there's a feeling that, listen, we've done this, everything's okay. Yet today, whoever said it earlier, if you're a black man or a black woman with peripheral arterial disease, doing a very, very careful analysis, you're 40% more likely to have an amputation than a white person. So why is that? So this is not going away, but I think we're in severe danger. And, Ponder talked about it earlier. We have to have panels like this, have these discussions and live into this. It's not something we can do and put in a end of year box of, did I achieve some goals? Let me put a DE&I one in there. We have to live it. But I think it's in real danger.
I think the DEI efforts that were started in 2020 across many companies definitely are in danger. But I think us in healthcare find ourselves in a unique position. And I actually take a little bit more of an optimistic approach than my wonderful colleague here. And that is because for so many of us, our sustainability and our growth is connected to solving those health inequity issues. Those are real patients. Those are real lives. So when we think about who we are, I'll just use Gilead, for example, and bringing our innovations to the marketplace. We can't be successful as a company, if we are not also addressing the inequities, because much of the opportunity are with those patients who are not in care, who are falling out of care. And those who are going to succeed are those that are able to actually close those gaps. And so I actually am a little bit more optimistic than my dear colleague, but I do think that the diversity work is definitely under attack. I'm gonna say one more thing, because I think it's important, is that in order for you to do health equity work and do it well, you gotta have diversity. Yeah. And you cannot do it without having diversity and without having not just diversity of thought, because diversity of thought without racial ethnic diversity, without gender diversity, without sexual orientation diversity is not diversity of thought. It actually is a preservance of power. I'll just leave it there.
I think that one of the things that's really important for us to go back to is the fact that what is actually causing these inequities? What are the biggest contributors to health outcomes? What we now know is that what I do in the office only accounts for 20% of health outcomes, right? And what we now know is that all of the social environment, the housing, the food access. And so I think one of the things that I've been seeing that can really move us around making sure that health equity is not an adjunct, but is core, is by making sure that we are creating models that actually address social issues. And then that is health equity. That is actually what's going to make the impact. And so what that looks like is, even here in New York, having changes in policy where we're reimbursing not just for clinical care now, we're reimbursing for housing access, we're reimbursing for food access. And I think once we start to centralize that allows for us to make sure that health equity is actually remains part of the conversation and embedded in our care.
I was going to say truly embedded, right?
Correct.
And you talked about policy, right? Someone earlier talked about, in order for us to get to that health justice you were talking, it's the policy systems and structures that the equity has to be included in there. Please, someone else.
Yeah, and maybe I'll just summarize and to build the conversation forward just a little bit further. I think I sit in a little bit in between all of my colleagues' comments. I don't think health equity is going anywhere because structural inequality isn't going anywhere. So inequalities are just going to increase. All of our theories say so. The data said so. It says so here domestically, but it also says here globally. We can see that in spillover effects in terms of policies. For example, we see policies proposing in Uganda, for example, anti-LGBT bills. We see that now in countries that are close by, for example, Kenya. These are how things work, and this is how policies get disseminated, et cetera. So I don't think that health equities will go anywhere. In fact, I think that they're going to increase, widen, get deeper. I think that what we should think about is how to reframe health equity in a way that works in our current system that is actually based on inequality. And I think for us to do so, I think we should think about health equity for everyone, if that makes sense, or how everyone as a society can mutually benefit from equity in different ways.
Valerie, if I could chime in, these conversations, these comments, they give sort of like a call to action for somebody at blackdoctor.org, because then we're able to, just being a marketing guy, I love numbers. And I'm looking at numbers constantly. Every minute I'm looking at numbers to the site. I'm looking at numbers to different ad campaigns. I'm looking at how people are reacting to certain words, how they're reacting to certain visuals, all that sort of stuff. But in the end, I can show how diversity makes sense, not only mentally, but dollars and cents as well. So giving that information to those powers that be and say, hey, look at these numbers here. We're able to actually move the needle, change the needle. So that just empowers me to say, okay, we need to partner with more organizations so that we can show these great results so that we can truly make some changes.
I like that. I wanted to go back with Dustin. You're flipping health equity sort of on its head, that we should look at it as we all need to be healthy, right? And it really does take all of us. And that has been a theme really running throughout the day. Can you talk a little bit more about what that model might look like?
I mean, to be honest, I think that I and others are just now grappling with what that means. I think that our current system of focusing on particular populations hasn't worked. And I'm not advocating for something versus something else. I think what I am is, I would say, an optimistic realist, where I really do hope that we have a world that's equitable. But I understand that our current everything is inequitable in every single way. And we've heard that today. I mean, me being up here is inequitable in the sense that I'm just one of very few. I mean, I know many of the Black professors in my field, which is not a law. In fact, that's something that we should be concerned about. I don't know the real the action steps, but what I think that what we need is some type of policy, which we've highlighted, and I'm sure we're going to get into, that it's clear that there's a benefit for everybody. I just don't think that there's buy-in. That's the sense that I get, and I think that when there this is my sense, when there are parts of buy-in, I get the sense that there's still a feeling of inequity. Well, I'm buying into this idea, but you benefit more than me in this way, when that antithesis may in actuality be true. So I'm not sure. I think that may be the magic question, but I do think that we need policies around that.
Realism, that's what I heard, right? And this work takes time. It's not an overnight. Someone said that earlier, it's not overnight. It takes time. And even conversations lead to learning and sharing, which leads to moving in some way of advancement, right? So let's talk about the kinds of commitments that an organization needs to have in order to ensure that a C-suite leader working in health equity is successful, is impactful, right? So you all are leaders in your own right, whether it's in research, whether it's in the community. How might an organization really show their support and commitment to ensure that C-suite health equity leaders are able to do impactful work?
I'll jump it off. I think a couple of things. I think one, the diversity piece is really key and important. And diversity from whether board of directors, whether in the C-suite, because you need people who are going to be allies and champions of the work and not dismiss it. I think we got to have data. We got to use data-driven approaches, understand where the greatest need is at, where the greatest inequities are. Also, be willing to have the commercial conversation as well as the policy conversation and the integration thereof. And then finally, is around partnerships. None of us do this work alone. And the ability to bring partners who've been in the work, but also partners who are new and who are bringing innovation so that we are all powered to actually address this and make a difference and move the needle. And then finally, I'll just say this, metrics, and have realistic metrics that actually give enough time to have success. This is not work that's going to turn in 6 months, in a year. You can't do an event, can't have an engagement for one time and say, hey, did you change infection rates or the number of patients in care? It takes a real sustained investment, and that's important.
Maybe I can just quickly round out another bit of, in the pharma corner here. Think about 10 to 15 years from now, this will be a majority minority country. It's an amazing statistic, right? But we've heard all day today about the health inequalities and the massive burden of disease in communities of color, people of color. So by 15 years from now, imagine the impact that that's going to have on healthcare delivery, on our resourcing for healthcare, and on the workforce. So I think the point about know the statistics and tell people what that will mean for their organizations is really key. So, to your point, get metrics, tell people. I think that's a way to engage.
So as someone who had to leave her organization, right, as a health equity leader, and then decided out of collective frustration to start their own company, because I will tell you the things that probably led to that exit. And hopefully that will help provide some color. One was money. So let's talk about the fact that many institutions are appointing people for health equity roles that are unpaid, that are unprotected. And also, even if they are protected and paid, they have no resources and no money to actually be able to do the work that is necessary on the ground. And so a lot of that work on my end was actually trying to have another job of trying to find money to be able to implement programs that truly serve my patients. The second thing is mindset. I think for most of the types of health equity organizations, it was, or I should say most of the health equity projects, it was prompted by an idea of how is this going to potentially, affect our bottom line, which is important, but there was nothing else behind it. So the mindset of really saying, this is the community that we are in, and we actually have a stake in making sure that this community does well. I think a lot of organizations are looking at their financials and not looking at profit and not purpose. And I think it's extremely important that is being shown in those organizations. I think the third is manpower. I think that many of us, right, only 2% of physicians are Black women, right? And that number hasn't changed in the 70s. So what's happening? People are coming in and people are coming out. And so the issue around this is the fact that we need to really think broadly about who are the other people outside of physicians to help support and help really allow for us to really engage. That has looked like community health workers, that has looked like navigators. Many of those are actually global solutions that came over here. And I think those are going to be important things for organizations to say, I need to invest in this. I need to broaden the caregiver and the care teams that really help to bring equity.
If I could just chime in real quick, just wanted to underscore what Rashad had mentioned earlier about the partnerships. But one thing he mentioned, which was so key, is the timing. when you talk about partnerships, that timing has got to allow for real metrics to be drawn from, and then tweak those metrics over time. Because I can't tell you how many stories that we have from people that email us, that comment on social media, that say, oh, I remember when you all talked about this 3 months ago. I was able to talk to my uncle about finally getting him to go to the doctor to ask him these questions that you all spoke about 3 months ago. Now he's going down the process of tackling this sort of issue that he had. But we get those all the time, but it takes time. It takes time for this audience to really wrap their heads around changing the course of their healthcare. So I think that was just an excellent point. Excellent.
So we talked about time and, I'm sorry.
Right, may I add one comment?
Absolutely.
Just not to repeat, but I think the importance of resources is obviously clear, but it's almost like it's the thing. We need resources to do everything, to eat, I mean, obviously, but I think it's missed. Prioritization is resources in a way. So when people don't prioritize things, there's no resources there. I'll say that. I think that the second thing we said was policies, and maybe if I just give one micro example from the research realm as a potential framework, but what I've identified is not only are there health inequalities, of course, but there are inequalities in kind of who does research, who gets research funded, where research is, et cetera, et cetera. We can go on and on. So I developed with colleagues a model called the Health Equity Research Production Model. And the entire point of the model is that we have to have a system of accountability for coming up, for having equity in how we engage communities, for who's on the teams that we research, for the who's on the teams for the grants that we write, like who's the PI, who's the MPI, who are the consultants, how much are they getting paid, and also for the papers that we write. These are things that to me seemed kind of standard and fairly obvious, but as a field that it isn't. And it's, I think it speaks to a lot of the synergistic reasons why minoritized faculty don't exist. And when we exist, many choose to leave or do leave because of these issues.
Yeah, agreed.
I want to just go back to your point, Derrick, about how do we begin to bring people along? Either one, but by educating them on level setting, what is health equity? We're in meetings, right? And people, what is this? Why should we support this? How does this align with our business unit? What's our return on investment? How do we begin, whether it's in our own units, our own teams, to bring people along, whether it's the communications, whether it's some sort of tool, or whether it's straight talk? This conversation that we've had all day today has been, we're preaching to the choir. We all pretty much get it. And there's a lot of new learnings from the different angles that we have received today. But how do we bring our colleagues who are not quite there, they don't quite, why are we still at this? What do we say to them? How do we bring them along? We know that it's going to take time. You don't learn it overnight. But is it sort of a check-in? Is it a framework that, introducing a way to show that there is impact in this space? How do we begin to do that? Anybody?
I have some thoughts. So when I was in academic pediatrician, I was, so I'm a public health professional and I do implementation science research. So the goal for me, probably due to my impatience, has been always having research that's grounded in actual program and being able to do that. And I think the way that I've learned to bring people along has been action and results. And what I mean by that is, for example, in the clinic, so I'll give you an example, in our clinical arena in 2016 after the Affordable Care Act, we found a number of new people in ambulatory care practices, which is great, right? But also a number of people who were living in really under-resourced households and who didn't need actually more clinical care, but they needed addressing housing, food, other employment, childcare. And so within an organization that didn't have that, we decided, look, we have to work from the grassroots place to be able to figure out who can we employ to actually be able to do that research and support these individuals. As time passed, as we continued to get funding for our little mom and pop shop, then we started to see, oh, wow, these patients have less claims. These patients have less hospitalizations. And now the other departments started to ask, how are you doing this? By the time I left, now 14 hospitals were implementing the screening tool that we use and actually engaging in navigator programs. And at this point, according to my colleague who still is at my organization, it is now embedded in their EMR. This is the largest health system in New York. And now they actually have a team that is devoted to addressing social determinants and community engagement. And so I think that the way that we do this is you see the problem. For me, it hasn't been around, let's think about it. And it's been like, what is the need? What is the fastest way and what in the smallest population that we can get to show results and then be able to bring people along in that way. And that's just one model and one framework.
and truly impactful. And so we're going to talk about framework approaches, the lens of research that we have used to make sure that our work is impactful. Can each of you share a framework approach, a research lens that might have made the work even more impactful, that sort of spell it out?
I mean, Rashad said that the comment about who we are and diversity, we talk about these things, but they're almost code words in a way, which is, I think, problematic, because I think we should say what we mean. As a professor, who writes a lot and thinks a lot, but having a mom who was a professor, I was taught that I need to be very careful about what I say, meaning I say things that I mean. Frame out from diversity, I would say we need position. We need people who have the lived experience to be able to understand the questions to ask. For example, I'm doing some new work in Kenya. I'm not Kenyan by any stretch of the imagination. In fact, my DNA lineage is West African. However, I understand that for me to do meaningful work in that region, I need to understand the people. I mean, that's obvious, of course. Mm-hmm. But what does that mean? Functionally, I have to learn Swahili. Functionally, I have to go. So these are things that I'm taking seriously, of course. But we need colleagues to understand, because I don't think we even know the right questions to ask. So the approaches that we do, I think, are totally, they're not in line with reality. Like what you're saying, this screening tool for a hospital, it sounds so obvious to me as a non-clinician. Right, yeah. So for the fact that clinicians may not see this obvious tool as being a not only cost saving, but actually helping people, to me, it speaks to the potential lack of position. I think we need position. Mm-hmm. That's one of my meetings that I had early yesterday. It was about position. We need people who, in every way, and when we don't have position, I think we need to garner position. And I think we can garner in different ways. Yeah.
I like that position.
Yeah. If I can just build, if I can build on that, I'm sorry. We're on a journey, mm-hmm. and I think that's one piece of this health equity piece, is that we are all on a journey, and there's some things that we did at Gilead that I am very proud of, and I just will share some learnings. One is that we actually built access and health equity as part of our corporate narrative and how we talk about who we are, and really sharing across the entire enterprise of all 17,000 employees of the work that we're doing in terms of health equity. That really is material, because sometimes people don't have the language. Right. And so one of the resources that oftentimes people need is, listen, I care about this. This is why I'm actually in pharma, or I'm in healthcare, but actually I was taught not to talk about this. How do I actually talk about this? What are the actual words to say? And so we did a number of efforts to do that. We actually are even doing some more. We actually stood up a health equity work group and task force and got executive sponsors for it to actually show that leadership was aligned up and down the organization and had representation across the enterprise. And then finally, which connects to the partnership piece, is really talking about the investments that we were making in communities that were most impacted by HIV or triple negative breast cancer, but not only talking about the investment, but actually talking about the impact that those investments were having, so that the company saw and employees saw, this is the impact these investments are having. And it really empowered people, and it gave them the information that was needed to bring them along the journey of health equity.
Wow.
If I could add to that, just like our other panelists say, it's not a one bullet thing. There's not one thing that you can do. But I believe one of the things that I'm most proud of is that we don't know all the answers. So we ask, we constantly poll our audience and we ask, we say, hey, what's important to you? Mm-hmm. You mentioned before in here, in this room, we're preaching to the choir. Well, we need to go out down to the pews and ask the folks in the pews, hey, what do you want? What's important to you? And we were able to do that with COVID. While in the beginning of 2020, when there's talks about vaccines, the first vaccine coming out, 90% of our audience said, hell no, we're not taking the vaccine at all. So then we asked, well, why? Why is that? So then they gave all the different reasons. So then we brought more information. We brought the best and the brightest from, Washington on down, and constantly not telling them what to do, but giving them the information so that they can make an informed decision themselves. Now, fast forward a year later, then it was, I believe, correct me if I'm wrong, I believe it was over 70% said that, yes, you were instrumental in helping me get at least my first vaccine. So it's just taking the time to simply ask. And sometimes we don't know the answers to ask. So just like with this health trust study that we did, we had Omnicom, we had other organizations with us. So we're chiming in with health professionals saying, okay, what questions should we ask? And then we go down from there.
Can I just,
Please.
I think one of the things that was really impactful about COVID that I'm scared has been lost in the sauce is when people realize, oh, okay, we need to vaccinate people. Let's just, give the vaccinations in the health centers. And we started to realize, oh, that's why none of our other health things have been working. Oh, and when we actually now had a pandemic on our hands and had to we realized we had to go into the community. We realized we were not the experts. We realized we had to go to churches. We realized we had to go to schools. We realized who were the actual people who were going to be the transformative change agents. And my concern now is that now that, things are coming back to, we're not wearing masks anymore, everybody's doing that, we're not realizing that these people in our communities are where health equity impact is going to happen. And we're not investing in that. We're not making sure that they're at the table in conversations. We're not making sure they're on our boards. We're not engaging when we think about an approach that is happening either in the hospital or in health centers. We're not engaging them to be able to contribute to why this is going to be helpful to the community and why it's not. And so I think that's particularly important in terms of a framework, even in the planning stages. Usually we come out, we're like, this is what we want to do. Do you like it? And that's community engagement. That is not community engagement.
You're absolutely right. Oh.
Valerie, can I just pick up on something Derrick said at the start? I think oftentimes we get hampered by the idea that you've got to do this huge, bold thing that's really going to solve a problem. Little things are okay, right? I mean, we chip away at a problem and we solve it. At Amgen, we have this thing called access to health, where we cover all sorts of stuff. Some we give drugs away to different centers around the world. We do education. You guys do it. I know you do great programs as well. And that, that's in India and Pakistan, throughout multiple African countries. We have programs here as well, like Health Equity Challenge in the US, where we then give out grants. We engage communities to come with ideas. So some of that's big, it takes millions of dollars. Some of it is small, but doing something is better than nothing. And chipping away, we will steadily get there. So I think as a framework, I like that idea because
we have to start somewhere.
You have to start somewhere, and you have to persist.
That's right. And if you're not starting, then that's the failure.
Yeah.
Someone has to ask the question and then say, what are we going to do about it? And then what are we going to surround this to support it? I want to go back to your point about community engagement. That's one of my passions, about making sure that the community trusts, understands, and appreciates the work. So talk to us a little bit about what real community engagement looks like. Now, you mentioned bringing them along, but I'm in a team meeting and someone says, we got to involve the community. Call your network, right? So How do we proceed, right? How does that really work? Relationships, right? Involving them at the beginning. How does that work?
Yeah. So, okay. So, I co-founded and CEO of Strong Children Wellness, and how we started Strong Children Wellness was not because it was this amazing idea that we thought of, but it was literally, it came from our community. It came from the communities we were caring for. And so an example of how we engage, or what community engagement looks like, is to be a listener. That is the first and most foremost thing. And so for me, any idea, any project, and I have this opportunity, right, as a clinician, is all from listening. One of the things where we started was actually, I work in Queens, and we have a huge undocumented immigrant population that we were having difficulty engaging with and getting in for vaccinations, and for many different reasons. A space where I found that they were actually a community was in Corona, Queens. Those of you from New York probably are familiar with Corona. And I worked with an organization that actually had an early childhood center there, and was a stalwart, was always providing services. And we just started to engage with them and say, hey, this is the issue that we're having. What are the thoughts? And they said, hey, can you bring a physician here to the school, to the early childhood center? And we can have some ask the doctor questions. You can do your assessments. So in that, what we found was we had a different engagement. Our parents were more engaged. They were talking to us. The kids were there. They actually asked us if we could come to their home so they could see what that did is it includes pillars of partnership. It included that pillar of being able to make sure that you are sitting back, and this is from collective impact framework, that you become a backbone organization, meaning that you are not the one driving it. You are the one just being able to say, oh, okay, in order to do that idea that you have, here's some money, here's some resources. But it's really driven by the community. So that model of bringing primary care into a community-based setting was actually the impetus for us to actually go for a grant to begin Strong Children Wellness, which was 4 years ago. And so that, I think, is how we start. We start with listening, and we start at learning. And then we now take that and we actually say, this is what we've seen. These are the issues that you already know. The community knows the solutions that are going to work already. They're just like waiting for someone who cares and will listen to them.
That is so true. The community knows what they need, right? Please.
Just want to comment on all of that. I appreciate it, and I think it's great. But I want to just highlight that, it's a problem in the current system of how academic research is structured and funded. None of that makes sense. Or put differently, it is very difficult for me as an academic researcher to do what you're saying. I mean, we've done that in the ways that we can, or as best we can. So for example, we don't just do work, we do work in community, literally by giving a subcontract to a CBO, and typically, you know, all the things. But I'll just say that to say the following: if we think that equity matters, then our current systems can reflect the prioritization, which is, for example, community engagement, if that matters.
Yeah. So one thing, just so everyone knows, since we're based here in New York, 5 years ago, there was something called DSRIP, which was basically a reform of Medicaid. The idea that we would put money in to organize healthcare organizations, and they would partner and give money out to the community-based organizations to be able to support providing a whole health solution for their patients. By any means, and this can be controversial, it pretty much failed. The organizations, the community-based organizations, received very little, although they were doing the majority of the work. Now, this year, that Medicaid reform has come back, and we don't mention, DSRIP is the name not to be mentioned, like Voldemort. We don't mention that name. It has now come back as health equity reform. But the change in it is now, they said no, it's not the big, massive healthcare organizations that are getting the money from Medicaid. It is social care organizations. It is the large housing organizations. It is the large food organizations. It's the large, huge behavioral health organizations that are getting this money, and they will decide if they want to give it to the healthcare organization partner or whoever that is. I think that's where we're going, where we're starting to think about who's in the community and saying that that is the work that we need to flip on our head and reimburse in order for us to be able to move forward and actually make some change.
That's good news on the horizon. Anybody else want to weigh in?
I'll share from an industry perspective. So over nearly 17 years ago, we built out looking at our HIV business, we built out an HIV community team. And we have community liaisons across the country who actually do real education work on the ground with patients, with allied healthcare providers, partner with communities and doing health fairs, many other things in between. But many companies actually pulled back from those sort of community teams. We've made the decision to lean in and actually even expand. And we've done that because it really does provide a powerful resource to communities and to our patients on the ground. And we actually connect our marketing teams with our community team to ensure that they are learning and listening. Because oftentimes what happens in industry, I've not always been in industry, but I've learned, is that sometimes a few focus groups will be used to make really, really big decisions. And depending on who is in those focus groups, actually dictates the insights that are actually collected, which then dictate decisions that are made. We actually pull through connectivity with our HIV community team to really ensure that we have a broad spectrum of insights. And I would say that's one of the ways in which we've been a differentiated leader in the HIV space.
Wow. Anyone else? Great models and approaches to engaging the community. We're going to begin to round out. And since we have this esteemed panel, we're going to talk about what do you see in 2024 as it relates to health equity? What's the outlook? Is it AI? Is it more community engagement? Is it health communications? What do we see for 2024 from your lens, right? Pharma, research, provider.
Well, I can start. I was having a talk with someone earlier, and we were just talking about just how to look at things. And just like we started off this panel talking about there's an attack on health equity, but I see it as an opportunity. So I'm optimistic because with every adversity, there's an opportunity for change. So looking at it differently, especially even with AI. AI came and then everybody, oh, they're taking my jobs. I don't know, But being able, the tools that I see coming out, especially when you talk about private GPTs and, just AI in general, it can really help in so many ways if used correctly. So the outlook, I believe, is more partnerships, utilizing AI to formulate those metrics that would really solidify partnerships to truly move the needle forward, as I see in 2024 and beyond. But I tell everybody, things are changing at such a rapid rate. How do we keep up? We continue to ask the question, what's important to you? Those things change for some people. What's important yesterday might not be important today. So we're constantly asking, constantly changing and tweaking in order to service who we need to service.
Thank you.
Oh, okay, we're going in order, sorry. So I think it's probably decentralization of healthcare and expansion of the care team. And that probably comes from, I think, 2000 was my first trip to Kenya. And after that, multiple trips to about 8 other countries in Africa and 4 other countries in Latin America and working as a pediatrician. And one of the things that I think is finally making it over here is the idea that, and it's sad, the financialization of healthcare has monopolized health into large institutions, right? And it has multiple barriers for the people who need care the most. And so I think what we're seeing now is, school-based mental health. We're seeing housing organizations that now are trying to embed, primary care my consulting company, one of the things that we're doing is trying to get BIPOC practice owners connected to nonprofit human service organizations so they can do more education, training, and more culturally responsive care can be in those spaces. So I do think that's important. And I think the expansion of the care team. I think there's a lot of heaviness there in the conversations about physicians. Yeah, we can't do all of it. We can't. And and a lot of it we didn't learn in medical school.
Right.
A lot of it we're learning now. And we're like, oh, yeah, none of this actually that I learned is actually what's making the difference. So we're learning it now. And I think what's been really nice has been having in our practice, having care managers who are from the community, who are doing home visits, who know people in the community. I think having navigators who are searching for the resources that are not medical. I think peer support, right? And having peer groups for things like cancer and being able to have those models and really expanding the care teams. Those two things, I think, are going to be really pivotal for how we move if it's funded and if it's really invested in.
Thank you.
Research. I think research is responsive to society, so research is determined by the funder. My assumption is that as we see kind of if the current trajectory continues, that we'll see more health equity research. And I think that's great. I think their work will continue to measure and document what exists and maybe new things that exist as time changes and people change. And I think that will include new approaches to help people improve their health. I think, unfortunately, though, that doesn't necessarily address the problem, which is the systems that create these issues for everybody, especially people who are most marginalized. So I would say my hope, I'll frame it as that, would be research that focuses on the systems and policies that create X, Y, Z. That's what I hope happens.
So I do feel very positive about the future. I think it's in our hands, and I think even compared to a decade ago, right, we're just in a different era. I think there's three things. One is democratization of research, AI, and precision medicine. Mm-hmm. Digitalization of clinical research is here and now, and it's working, and it does democratize research. Whoever said earlier, you can't always get to the Mayo Clinic. Maybe you're out somewhere else, and that's a good thing, right? So more and more people will come. I would say an interesting fact to me is that at Moderna, we actually halted the COVE trial during the pandemic to ensure that we had racial representation in that study. We stopped it to ensure that we had about 30% representation of people of color. When we rolled out the vaccine, it was still a disaster for communities of color, right? It took huge partnership, as we heard from organizations like this, to then really get the implementation science to work. But I think democratization of research, the FDA guidance, that's very positive to me. AI, I don't think we can imagine what AI will give us even 2 years from now. That's right. It's like, do any of you ever remember a Sinclair ZX81? You're all too young. It's this little computer. Like you could get it to, write your name. You could put in what it was and it would say, "Hello, Paul." Well, that was 1985, right? It's not that long ago. But so the pace with which, to your point, things are moving. We can't even imagine it. But I think the opportunity there is massive. But we have to just keep a careful eye on inherent bias that goes into algorithms. It's clearly going to be very important. So that's key. And finally, precision medicine. If we can get funding and we can get algorithms to work and we can democratize and open up that kind of research to people, then I think it will take away bias treatment and just terrible outcomes for certain populations. So I think those three together, they give me great hope.
Thank you.
We didn't share talking points.
And he got to go last. So.
And I get to go last. So definitely I'm excited about precision medicine. I think that what that innovation and therapies is going to bring to us is going to be, we really don't fully appreciate and understanding. I think AI, all of us are excited what AI can do in the ways in which it's going to transform all of our lives in every way. I think the big cautionary note is that humans built AI, and that humans have been known to have bias and unconscious bias, and how that has been embedded into the system. And that we have real caution in how much we rely on AI and our decision making, and that we are asking the questions, and we're asking questions that are connected to health equity. We're asking questions around diversity and around inclusion, because if we don't, we will find ourselves in a situation where AI will have only exacerbated the inequities that currently exist.
Well, I'll just add my outlook for 2024, and I would say more of these kinds of conversations. Please join me in showing appreciation for this incredible panel. Thank you. So from today, you heard we have work to do. We have a lot of work to do in health equity, and I hope that we would use this network, this forum, to continue to tap the people in this room. Right? These are the experts, the people close to the ground, our community partners, our inspiration. Use this network and think through what you might do together in 2024. I'm just going to do a plug. Next month is Black History Month, and April is Minority Health Month. What are you doing? Right? And if you're asking yourself that question, you're too late. So I'll just say that because you started planning anyway. I'm just going to say that. So I want to thank you again for this opportunity. This has been tremendous. What learning we received. And I just want to thank USA Today. I want to thank blackdoctors.org and all of you for being here. And I'm going to toss it to Reggie. Thank you again. You guys are.
Wow, what an amazing day. I love it when we can come together, have great information, and become smarter because we've been here, because we've listened, because we've had these conversations. That's really good. I would say that a couple things. One is, this was such an amazing day. We definitely need to continue coming together, having these conversations. So I'd love to do some other conversations like this, different locations throughout the country. Another thing is in April 24th, I believe it's April 24th, we have our annual Top Blacks in Healthcare event. And it's just an amazing gala. Ponder was recognized last year as one of our top honorees. It's just an amazing event. And I invite you to come down to Washington, D.C. We have it every year. And it's an amazing gala, but also we have thought leadership. And we're going to have thought leadership there as well. So it's going to be just an absolutely wonderful time. And then the last thing I want to say is that the takeaway for me is partnership, right? We've got a lot of people, a lot of great ideas, really, really smart people, great companies. And we've got to continue to walk together, right? Because what do they say? If you want to go fast, you walk alone. But if you want to go far, you walk together. We need to go far. Thanks, everybody.